we could go ahead and get started.
Okay, thank you, Becky. I'm glad to introduce this presentation today. We have three speakers today. The first is Jan Gaddis, and Jan has worked as a faith community nurse at Franciscan Health for nearly 25 years. Currently, she is also with the outpatient palliative care team at Franciscan. Jan has worked at Holy Cross Church as their parish nurse on behalf of Franciscan Health, and her background is in pediatrics at Riley Children's Hospital, DNS, Wishart Hospital, and the Indiana School for the Blind and Visually Impaired. Currently, she is working on an advanced care planning initiative for outreach to faith groups utilizing faith community nurses. Jan is a board member of the Indiana Center for Parish Nursing and Health Ministries. I'm going to introduce our second and third speaker now, and then we'll be able to roll right into them when their turn comes. Amy Todd will be our second presenter, and Amy is a registered nurse with over 19 years of combined experience in acute care services such as post-surgical, medical, renal metabolic, cardiovascular surgery, and medical, neurological, and hospice care. She is also highly experienced in administrative nursing, focusing on case management, reimbursement services, care collaboration, and mental health. She currently lives in Martin County, where she works in a faith-based nursing program, giving her important lived experience as a member of a rural community consistent with focused population-based needs. Amy serves as project manager for FaithNet, a health resources and services administration grant. She is responsible for facilitating community and hospital connections associated with grant activities. And Amy also serves as the chairperson for the Martin County Mental Health Task Force, where she has existing partnerships with health and human services and hospital leaders who regularly attend meetings. And then our third speaker will be Katherine Pope. And Katherine currently serves as the health liaison at the IU Center for Rural Engagement, where she strives to help rural Hoosiers live their healthiest lives. Originally from rural Indiana, Katherine has recently returned to her roots after launching and serving as the program director of Sky Lakes Wellness Center in rural Oregon, where she worked to improve health through clinical medicine, built environment initiatives, and community collaboration. Katherine holds a Bachelor of Arts in Modern Languages and Literature from Kenyon College, a Bachelor of Science in Nursing from Indiana University, and a Master of Public Health from Johns Hopkins Bloomberg School of Public Health. She is a current doctoral student at the IU School of Public Health and serves as Fellow of Indiana Rural Health Association. So again, very excited to introduce this wonderful group of speakers, and now I will turn it over to Jan. And you are muted right now. But...
All right, thank you, Don. And thank you for the invitation to be here today. Even though we're virtually, it would be exciting to see you in person, but trust that all is well. So I'm going to go through these slides pretty quickly. It's a quick overview. Then my colleagues will follow up with it, but I've just given a quick overview of faith community nursing. And you'll have a copy of these slides. So next slide, please. So that you'll be able to go back and review over them. So it's just a beginning again, and then what are the next steps? So it's a very quick overview, looking at that partnership and collaboration and the principles and models of health ministries, particularly out in the rural communities. Next slide, please. So as he said, my background's pediatric nursing, but all of my nursing career has led me up to here and now today, and to embrace this faith community nursing. My work at Riley, my work at the blind school, I took care of patients and students who were from across the state of Indiana. So even though I'm a city girl, I have some connections with the rural health through my patients and students through the years. Next slide, please. So through my years of nursing, and particularly 25 years as a parish nurse, a mission involved is about building those relationships, the trusting and caring relationships, making connections, which is about the partnership and collaboration, and then being of service, and that's being a healing presence of Christ for others, for myself. Next slide, please. One of the beginning points of maybe this integrative work of nursing and spirituality was through the story of Billy J, a patient I had back in 92, 93 with cancer, and he passed in March of 93. And it was a mystical experience for me of having the joy in the midst of sorrow. And that led to a lot of reflection within my part and a lot of exploring different traditions. And it was a turning point in my nursing practice because I knew I'd never do it the same way again. And it was a preparation then for the next 25 years in nursing, parish nursing, and then palliative care. And Billy was my teacher in all this. So next slide, please. So one would ask, what does a parish nurse do? What do you do? And so I typically say it's about being a parish nurse. So there's no typical parish nurse day, no typical parish nurse. So it's whatever the calling is within the nurse and the community to bring that together. And so different functions that we may do, different activities, a lot of visits, church visits, hospital visits, office visits, street visits, but including that pastoral care, the spiritual care. We would have health fairs, we'd have vaccination clinics, caregiver support, prayer services, assist with sacramental needs, and a lot of end-of-life care that I found in our community that was American Heart. I worked with nursing students. I learned a lot. We had to document. Next slide, please. So as my practice expanded and connected with the national and international agenda for parish nursing, faith community nursing, it's looking at those life transitions, that culturally congruent care, working with the homeless and marginalized in our area at Holy Cross, and that including the mental health care, networking and collaboration about population health, health promotion, and those self-care principles. That's one of the core things for parish nursing, faith community nursing. We advocate, we educate, we navigate. Advanced care directives was a critical thing that was of interest to me, and it continues to be. And just looking, connecting with that larger, the research and documentation for the journey, which aligns with so much that we're talking about here today. Next slide, please. So this is my favorite slide of looking at what is parish nursing. So it's an integration, it's both and we're looking at faith and health, of course, nursing spirituality. It's that nursing care and spiritual care. It's the active work of doing things, but also being, so that contemplative sense. It's local and global, and of course, rural and urban settings. Next slide. So what is parish nursing? So Granger Westberg, really in the 40s and 50s and 60s, but he taught at Lutheran General Hospital in the med school, and he was looking at faith and health through all these years as a chaplain, but he was taught in the med school and starting to make that link between healing and whole person, and knowing that nurses may be that link. So they started with a health clinic that wasn't sustainable at that time. So they found that they place a nurse in the church. And then we developed the Parish Nurse Resource Center, and it's all evolved from that time. We are recognized by the American Nurses Association as a specialty practice. And in 2005, changed the name to Faith Community Nursing so that it would be aligned with other faiths and cultures and traditions. Before, it was assumed it maybe be Catholic, Episcopal, Lutheran parishes, but it's faith-based and tradition. Next slide. So to be a faith community nurse, a registered nurse who practices holistic health for the self, but individuals and the community at large. There's paid and unpaid positions, but it's really looking, the focus is that intentional care of the spirit. And it's for the faith groups, the churches, the congregations, the communities outside, and looking at the whole person, mind, body, and spirit. Next slide. And the philosophy and concept of faith community nursing is the assumption that we care for ourselves and care for others as an expression of God's love. And looking at some of the concepts of spiritual professionalism, holistic community, that prevention, looking before serious illness, perhaps to prevent hospitalization, that ministry of presence, and being that servant leadership. And there are some tensions with church teachings and health teachings, so just holding the tensions. And again, we look back at that both and. Next slide, please. So to become a parish nurse, a faith community nurse, an active RN, you'll need to be a license in their state of practice. They prefer BSN, but my 20 plus years was as a diploma nurse, so that is still good. There is a course to take, Foundations in Faith Community Nursing, or a course similar to develop those roles. We're working now with Marian University undergraduates, and they are already working towards integrating their faith and health. It's the RNs that have to unlearn what they've learned to know and to embrace these new skills. So it's quite exciting to be on that cutting edge there. And next slide, please. So the course is typically 36 credit hours, or you can take it for credit hours. Like I said, we're at Marian University with undergraduates, but typically it's for the RN for the course. So again, this is going by very quickly. We have educational partners at Marian, in Lafayette at Community Health Bowl, and then USI down in Evansville. And I'm sure there's more out there. We just need to connect with them. Next slide, please. So the practice is governed by the Nurse Practice Act in each state, our nursing scope and standards through ANA, and then ANA and HMA collaborated and had scope and standards for faith community nursing. So there's extra competencies for that. And again, that's looking at the intentional care of the spirit. We go by our code of ethics. We need to practice with confidentiality and abide by the HIPAA guidelines. The legal aspects, the liability, it's perhaps encouraged that you carry liability. I am a paid model, so I'm paid by St. Francis and covered under theirs, but I do have extra liability for my practice. They do ask to perhaps the car insurance liability, because you're out in the community moving around. And then the documentation. So keeping records, that's what nursing does. It's very important. It's legal documents, but we haven't found the ultimate documentation, but there's a lot of research out there. There's a lot of data collecting, and it's a growing edge. So we are documenting our journey. Faith community nurses do not do medically ordered care, but we do follow our Nurse Practice Act. We have autonomy and we follow our scope and standards. So next, yes. Here we go. So in 98, again, we say, we're providing that care to individual groups, families, communities, populations. So we're looking at that healthcare consumer and promoting whole person health. Next slide, please. And the goals of faith community nursing, as in all nursing and healthcare, is looking at protection, promotion, and optimization, prevention of serious illness and injury. We facilitate healing, alleviate suffering, and a lot of advocacy, and looking at in the context of values and beliefs and practices. So what does distinguish is again, that intentional care of the spirit. And so the extra learning and teaching of spiritual care. Okay, next one. And again, we're looking at that mind, body, spirit connection. Next slide, please. So the different models of health ministries. As I said, I am a paid model, but there's paid and non-paid. The part-time, full-time, I'm a part-time from Franciscan to work in my community. We have 20, 25 others that are professionally non-paid volunteers perhaps on staff at the church, maybe not, but I have a vision, and this is where I think critical access hospitals could be, is looking at that hybrid model where the nurse would work perhaps 30 to 35 hours at the hospital in acute care bedside, and then be paid, these next generation that we're trying to recruit at the community level, be in their churches or in the community, promoting health and doing prevention and doing all the things that that says in our scope and standards. There are other models of congregational health models with or without a faith community nurse. So a lot have health ministries, but they don't know it or claim it, but they're going to pray for the sick. They're attending to them. They're attending to the end of life. So that is there. So it's just formalizing it more. There may be congregations with the Stevens ministry and providing care. So it's a both and, as we said before. Next slide. Talked about the partnership and collaboration. So when I first started, it felt like you were out there all alone, but there's so many ways to connect, and we need to stay connected and not be so siloed, break down those silos and not duplicate services, but provide that support for each other. And again, we want to collect stories and information so we can document it and get metrics and what's the ROI and all that. So these are my personal support and connections. Like I said, across the state of Indiana, we have IU Health, Ascension Health. We work with Franciscan Community Health Network, Marion and USI, and there's so much more. And I know you're all out there now. Met Amy and Katherine, so we add to that. Next slide, please. So I worked with our population health specialists at Franciscan, and of course, all not-for-profits are to do their community health needs assessments. So this is where this was gathered from there. Looking at what are those key health needs in the rural area. And that social determinant of health is a big one. And I think Katherine's had some conferences and they're attending to these. So this is very exciting to know that we are starting to work together so that we can find solutions. So faith community nursing is a great piece of that. Next slide, please. So the benefits that we found, and you may know more than I do, but these are the benefits of faith community nursing, and I think reach out into the rural communities with that strong connection in our rural communities, in our faith and churches. Prevention screenings, organizing, it help navigate to decrease confusion about the healthcare system, educate, meet them where they are, provide help and assistance, answers, what they may be. And again, it's that looking at that whole person. Next slide. I think Amy will talk more of that. We look at the whole lifespan now. So my specialty background is pediatrics, but I'm working the whole background. So I've got their grandparents now, and it's that follow-up after death too with the loved ones and the bereavement. So you know generations, and you know history, and you know where they're going, and the little one that you knew is now, you know, a mama themselves. So with that growing population of 65 plus, we can be a great support out there. There's a lot of creativity that happens, and it's at the grassroots, and that's where the strategies can come. And for example, we're using our advanced care planning and outreach into faith groups. And being that ministry of presence and practicing and learning and cultivating that. Next slide, please. So as I said, I was a diploma nurse, but at age 60, I went back to school for the BSN, and I wanted to study about faith community nursing and how would that make an impact. And we aligned with the National Westberg model of transitional care to decrease hospital readmission rates. So next slide. At St. Francis, we have a accountable care organization that really was doing a lot of transitional care. So how do we fit into it? So I adapted how we can work with, and it was great success. It was a small project, it was for school, but we've continued to help that support through that continuity of care into the community. We bridge that gap in that transition of care and increase that quality of life and decrease readmission rates. And then which led for me into that palliative care support. It's critical. Next slide, please. So this looked like a busy, but this is a model from 2014. Memorial Hospital in Jasper was part of the research for this, so that we can talk about that later. So there's a lot more information and evidence-based practice on this. But utilizing that faith community nurse in that transitional from home. So next slide, please. So that transition from the inpatient to that home patient to the home setting, that transitional care. So these are some key ideas and interventions they thought of. Next slide, please. So faith community nursing have a lot of interventions besides the typical interventions, but we like to be that whole person, and so providing extra support. The next slide, please. All right, so there we go. This, so the honeycomb effect shows a lot of interventions we can do, but here are 6 key interventions. Back, please. Yes. Resource coordination, medicine review, and self-care education. So that's what they identified as the key interventions for how faith communities can help that transitional care to decrease readmission rates. Next slide, please. So just a quick of the strengths. It was a very positive, well received. I was the only person doing it though, had community resources. It was great and exciting to do. My lack of, and my weakness was the lack of medication reconciliation, and that is a huge, huge issue, and I still don't know how we accomplished that. I still see that as an issue, but we're all working on it. And I know Qsource is that great. It was a collaborative effort with Qsource at the time as a team effort. So next slide. And we did show clinical significance with it. The statistical really, we didn't, it was just a quick little thing that we did, but I think the potentiality of it is great. So I would recommend this to continue. And so I've got resources if you'd like to know. So next slide, please. With that, then through that transitional care model, looking at the palliative care, and again, going upstream and going before they get sick, faith community nurses can definitely assist with that. And which then now led to working with a DMP for the project of advanced care planning in our faith group. So there's more of that to come, which we can look at. Next slide, please. So recently, within the last year, Westberg Institute, which is our international connection, merged with Spiritual Care Association to help increase that nursing and spirituality for the professional, not just the nursing, but social work, physicians, anyone. So looking at how to cultivate and learn and be and practice that spiritual care. And I have some examples of some spiritual assessments that are very easy to use, the FICA and HOPE. So more information if you like on that. So I always say we don't know what God has in store for us. And so it's partnering with God too, or that higher power of what's happening in our life. The next slide, please. And I'm glad there was an attention called to self-care. So faith community nurses, one of their anchors is looking at self-care within ourselves, but helping that self-management within the community. So health coaching things. So the model of healthy living from Church Health has a great way to look at a wheel and to assess how we're doing, to look at that work-life balance, to bring in creativity, the mindfulness. We had that practice just recently. What kind of meaningful relationships are in our lives? How do we build resilience and celebrate those joys too? We care for ourselves first as we care for others. So next slide, please. So in summary, and I think I'm about there, we want that continuity of health. We're looking at education and prevention. Transitional care is a critical point. We're looking at partnership and collaboration, the integration of faith and health, help navigate to decrease readmission rates at the hospital. work towards population health and culturally congruent care, promoting self-care, self-management, and advocate and assess resources for whole person care. And so I have a call to action for you all, and my colleagues will continue with this here, but I would call for you to get informed and increase your awareness of the benefits of faith community nursing, provide education and support, especially funding for faith community nursing courses, preparation courses, and integrate whole person care into your practice and include that spiritual care. So I thank you for listening and for viewing. It was a very quick overview, but you'll have these available, and then you'll have my contact information, and I'd be willing to come out and do this slower and more comprehensive than anyone. So thank you very much. Turn it over to my next. Thank you.
Thank you so much, Jan. Now we'll turn it over to Amy Todd to talk about her work in Martin County.
Thank you, Don. Thank you for your introduction, and thank you everyone for having me here today. Today I'd like to talk to you a little bit about the innovations and intersections of faith community nursing here that's been done in Martin County, and the impact of being community engaged with partners and the collaborations I've had as a faith community nurse. Next slide, please. One of the things that we learn in our course as a faith community nurse is the impact of starting with a mission statement and a vision. So when I became a faith community nurse in 2016, that was the first thing I did. Most organizations, they create a mission statement and a vision, and their policies, their procedures, their standards of operations are driven by that mission statement and vision. So bringing a parish nurse program into my community, my faith community, I thought it was very important to create that, to drive care, and to start that off so that not only did it bring out best outcomes for my parishioners, but also feed into the community. What I was surprised by was where I am at now, and that is that it has impacted beyond my community, that I am working in places with grants and in collaborations with the Center for Rural Engagement and beyond. So I am very happy that I started with a mission and a vision statement that was able to do that. And so that's my best advice for anybody that goes into faith community nursing. Next slide, please. So one of the main things I adopted in my vision was that as a parish nurse coordinator, I would help optimize the spiritual, physical, intellectual, creative, and emotional health through the specialized nursing care of advocacy, education, and prayer. And I included community in there. And I want to point this out to everybody because I like the word SPICE, S-P-I-C-E. It's easy to remember, as you can see, spiritual, physical, intellectual, creative, and emotional health. And we integrate that within our community, faith community nursing. And I like to talk about this as an easy way to remember. You all talked about self-care. And this is when we talk about creating foods, and we talk about adding the spice. And if one spice is off, our food is not going to taste well. It might make us unwell. We might get food poisoning even. And so when I talk to patients in my community or my clients, when our physical health is off or our emotional health is off, our relationships are going to be unwell. Even our relationship with ourselves is going to be unwell. So to me, this was a very critical part of faith community nursing. And it was part of what drove my vision, and it related to the community. It was important to include that. So anytime I'm doing a collaboration or a partnership, I go back to the 5 spices and the 5 spices in the community. And I wanted to make sure and include that in this presentation for you all to hear, so that you could take away this in your own lives and make sure and practice that. If you're having trouble in your work life, in your home life, in your prayer life, what spices is off that's making you unwell. Next slide, please. So when we talk about the social determinants health, we know those are conditions in the environment where we live, work, play, worship that affect a wide range of our functioning and our quality of life health outcomes. So economic stability, for example, 1 in 10 people in the United States live in poverty. And we often think of economic stability, we think of how it affects the job market. And we think about present and the future. But when we think about the present and the future, we also need to think about our children. So our children's growth and development are usually negatively impacted by poverty, and they get exposed to unhealthy lifestyles such as unhealthy eating and having difficulty with school, and they're less likely to attend college. And this definitely impacts their health and wellness. This has a definite impact in rural communities. The education and access of quality that involves how those children are impacted with school, because they're less likely to be able to attend school on a regular basis. We've seen that adults in the community are less likely to have good employment. And we're also seeing more often that in rural communities, they're generational farmers. And again, they're less likely to have good health and well-being from that access to higher education. When it comes to the healthcare access and quality, we have, especially in Martin County, we have a lot of patients that access the emergency department as their primary care provider, rather than having a consistent primary care provider. So then we're combating situations for preventative care. They're not accessing screenings routinely, or having managed blood pressure, medication management, or resource referral. And then with neighborhood and built environment, this also is a major impact for our social determinants in health and how people live. When you consider change theory, for example, we talk about individuals' knowledge and beliefs and how that impacts their individual and interpersonal relationships. And then we involve organizations and institutions and how they work in their communities. But if we don't have those institutions that can impact the community to help build and strengthen the access to quality care, then we're going to continue to have those cycles where we're not improving health and wellness. And so we continue to have poor health. And that's where I think the faith community nurses can come in and help drive better standards of care and help improve life and help improve our social community and context. Next slide, please. So factors that affect our health and well-being, interpersonal relationships, again, those interactions among family, friends, and coworkers and communities that impact our health and well-being. A lot of times people face challenges that they can't control, such as unsafe places, discrimination, and expenses. Those negatively impact their entire life. And we need to be able to find ways to build and foster positive relationships to reduce those negative impacts, so that they can build healthier wellness and reduce things. So, for example, when we talk about the socioeconomic factors, those have the largest impact on patients. A person is not going to want to listen to, for example, they're not going to want to listen to how to track their diabetes and follow what diabetes medication is if they're hungry, if they live in poverty, and if they need to attain food. They're not going to maybe necessarily get their thyroid medication if they need to worry about buying formula for their baby. And we can bridge that gap when a faith community nurse comes in, because we need to make sure that that patient's basic need, human need, is being met first. So when you have a patient that is having these risk factors that are known through social determinants of health, and you refer them to a faith community nurse, the faith community nurse can come in and say, I know of like the Mary Potter Resource Center that's connected to Memorial Hospital that can help you afford that medication you're not getting. And you can then take your thyroid medicine and buy the formula for your baby. So you're not putting yourself at risk anymore for not taking your medication. Those are where those gaps can no longer be causing problems for the patient. And then by doing that, it also impacts the community. It impacts the community because then you have a patient that's not at risk for having some type of long-term effect that then impacts the burden of cost on a hospital, emergency room, or the family. So next slide, please. So in Martin County, in the evidence here with Martin County, we have a patient to clinician ratio of 5,113 to 1. And we also have over 20 churches in our region. So those 20 churches also, even though they have the impact of being able to bring volunteers to our community, they also have the impact of bringing in influences towards health and wellness, one of which is mental health. And that's where I decided to start being more involved in my community. I was exposed to a lot of young teenagers who were struggling with mental health, that were starting to self-mutilate and having suicidal ideation because they were struggling at home because of religious beliefs, that mental health was not a health concern. It was more a religious issue. It was beliefs that it was from the devil, or something that they did as a result of sin. So as a faith community nurse, I was asked to step in among a lot of families to help have that conversation, to help these struggling teenagers, and became more involved. And studies have shown that with the hierarchy of needs, there is a transcendence with self-actualizations. And we have also learned that our quality indicators, there is measures in there that hospitals are reimbursed based on how patients report how they're made to feel when they're in hospitals. You know, sometimes they report that the way staff made them feel impacted how they felt their overall care was. It didn't matter that they received a large amount or quantity of care. It was how they were made to feel. So, and it was also discovered that a lot of that, how they were made to feel, was revolved around their spirituality. Next slide, please.
Amy, this is Don. I just wanted to let you know we have about 5 minutes left before we need to turn it over to Kat.
Oh my goodness, I'm so sorry.
It's okay. Doing good.
Please move on. Yeah, so we'll go ahead and skip this one, the root cause analysis, and please skip. And move on, if you don't mind. I just want to go on to the and keep going. keep going. So I want to go to this slide real quick because I partnered with IU School of Nursing and Indiana Center for Rural Engagement. And this is a slide that shows a direct impact with the Indiana School of Nursing students. As you can tell, we brought in students who were able to provide free preventative health screenings, and the direct dollars for savings on social cost savings avoidance for social determinants of health was $7,187.50. Now, the $1,200.50, that was a patient that had seizure-like activity, so that was a little bit different. Of the 48 patients that we saw in the short period of time, we only had one patient, or we only had 5 patients that had normal lipid values that we provided in our health screenings. Next slide, please. So when we talked about the social determinants of health, most of the patients that we saw actually came into our clinic and they were highly educated and change makers in our community. So I was really surprised that the plan was to bring access to care for patients in our community that were less likely to see providers, that were less likely to have seen providers because of the pandemic. And I really thought we were going to reach those people. The results, when I had surveyed people, I was finding that people felt like that IU was coming and they wanted something in return. There was a lot of feedback that they didn't understand why they were receiving a free service. So there was a lot of survey results that we needed to approach the community a little bit better and explain that this is truly a free service. We're not gleaning anything off of you and getting you in the doors and then, you know, playing doing the, now that we have you here, we're going to do something else other than what we said. But what was really interesting to me was that in this, during this screening, even with the highly educated people, we discovered, these are a list of some of the lipid profiles. And like I said, we only had 5 that were normal. And statistically, I'd seen some research that showed that even though, and you can go to the next slide, please. And one more, next slide. Let me come back to this. And one more. Oh, another one. So I had seen Maine Rural Health, the Rural Health Hub has an information on a project that Maine is doing, Franklin Memorial Hospital is doing in Maine. And they did a study that showed that higher education people are less likely to show an impact on doing preventative screening because they already go to the general health to get their health status checked. They're already doing all these preventative clinics. So it really didn't show a big difference. But the way a faith community nurse comes in is they really can reach out to those people that have low income, that don't have the ability to go and see a provider more often. But the results of having these free preventative or these clinics from their study, they showed that the cholesterol screening overall had a increased cholesterol control of 28.5% within 40% of the adults. It had smoking quit rates increased to 21%, and the decline in hospitalizations per capita was nearly $5.5 million in reductions. That's a great amount of data that I found was interesting for us. And in our program, one of the things that came about, we had 3 specifics that I pointed out on the slides that you can go back and look at. And that was, we had one patient that had come in that we discovered during the program that had a high amount of cardiovascular had a cardiovascular risk when we did a therapy screen. He was highly educated, had a BMI of 35. And we ended up doing a therapy referral, and it turned out he had already had he was already in therapy, but they didn't realize that he had such a high amount of cardiovascular history. He had come in with having a fall that morning. He had, he was on aspirin daily. He had had a history of cardiac surgery. He was having dizziness, and he had a very high diastolic blood pressure. He had a lot of markers for a need for a cardiac referral, and he was already being seen every week by therapy. By having this screen, we were able to have a conversation with the therapist and get him in right away with the physician to moving forward to that cardiology. It made sense that these preventative health screens and having involvement with that next level of professional nursing helps our community in many ways. And I actually had a lot more than just him and the 3 that are listed that was able to move on to referrals and resources. So I do apologize for spending too much time on other things. And if you have questions, I'll put my email and phone number in the chat box so anybody can reach out to me. Thank you.
Thank you, Amy, and you did a great job of covering a lot of material, so we really appreciate it. Our final presenter in faith, talking about faith community nursing, is Katherine Pope from the IU Center of Rural Engagement. And so I'll turn it over to you, Katherine.
Thanks, Don, and thanks, Amy and Jan, for such wonderful and inspiring presentations. I feel really honored to be able to close today's discussion. To be honest, I come from a very different perspective. I am not a faith community nurse, and frankly, wasn't really even aware of the work that they were doing. I've never worked in a religiously affiliated institution. I am trained as a nurse, but had always just worked in hospitals and in public health. And now that I'm at IU, I knew that we were having trouble getting the trust of community members when we were doing outreach. So we wanted to partner with a trusted community organization, and someone mentioned that churches might be a good idea. That sent me down this path, and I've worked with Amy. She helped me with the grant application that ultimately funded the project that Amy was describing. And through that, I've learned so much about faith community nursing, and I'm eager to share what I've learned and give some ideas about next steps from my outsider perspective. So next slide, please. Jan and Amy have already talked about Fcns, of course, but again, as an outsider and as a public health provider who marches to the drum of evidence-based practice, I wanted to find the research and the evidence behind Fcns. Their role is relatively straightforward, or as straightforward as a nurse's role ever is. They have to be registered nurses, as Jan mentioned, who have the extra component of faith in their nursing role. As with a chaplain in a hospital, the denomination is not the critical piece, and Fcns can come from any faith. According to the Pew Research Center, over 80%, or the vast majority of Americans, identify with some form of religion. Fcns provide the spiritual piece to healing instead of only focusing on the body or the mind, which we often overlook in healthcare. However, this can be the key component for healing, if not the most important component for some of our patients. Next slide, please. So I know that Amy and Jan have touched on this, but I want to just go over what the research says as well. And I wanted to see if it made a difference or not. Do Fcns actually improve health outcomes? So first, I combed the literature to understand what they did, since there are many different iterations, even right here in Indiana. One study found that Fcns performed 1,556 different interventions, most of which focused on providing coping assistance, communication enhancement, and patient education. But as you can see, as have been mentioned, there's a wide variety of services that Fcns provide, from patient navigation to support and counseling to delivering programs. Like all nurses, Fcns fill a wide variety of roles. Next slide, please. Unfortunately, there's a scarcity of quality data that demonstrates the effectiveness of Fcns. And I suspect that this is because their energy is being put into doing the work, which can leave little time for studying that work. Most of the studies, unfortunately, did not have control groups and weren't comparable studies. So they had different interventions, their measurement tools were inconsistent. So unfortunately, I cannot unequivocally say that Fcns improve patient outcomes. However, expert opinion, pilot studies, and intervention studies do suggest that Fcns can be successful in primary prevention, health maintenance, cardiovascular health, and cancer-related efforts. They provide health education and navigation, all efforts that we know can potentially reduce costs and readmission rates. Experts recommend their use, especially in rural areas where there are healthcare shortages. A recent systematic review that actually just came out this year said, particularly in rural communities, Fcns can play a unique role in public health interventions. They're known and trusted members of their communities, and they have the training and knowledge to disseminate current and accurate health information in both faith and community settings. So during this pandemic, with often inconsistent health messaging and a hesitant population where religion has been associated with not receiving the vaccine, the need for trusted faith-based care is evident and could be one of the keys to increasing vaccine uptake and improving public health, which, as Dr. Weaver mentioned earlier, is more important now than ever. Next slide, please. So what role can you play as critical access hospitals? I had really hoped to come to today's presentation with a clear idea of funding that I could offer, but as of today, that hasn't happened. At IU, we are currently speaking with some state agencies who are considering funding faith community nurses. But if you're interested in this, don't wait for that, because this is government funding and we all know how that goes. This is a prime opportunity right now with potential cost savings and could be a potential solution for some of the acute challenges that critical access hospitals face. Next slide, please. So as I mentioned, I've been creating a proposal and will continue to work on this to fund a faith community nurse position at critical access hospitals with the goal of improving patient outcomes, patient satisfaction, readmission rates, and healthcare costs. Next slide. The rough proposal for this position is to fund a primarily outpatient liaison focusing on underserved rural areas who would do the work like Amy has done, but who would be able to do it full-time with a salary. Telehealth technology has exploded over the last year, and I know Becky will talk about that later, and this would be a key component of the position. For example, the Fcn could do a home visit to see the patient and see their primary care provider remotely, a visit virtually facilitated by the Fcn. In this way, you can actually bill for an office visit. IU Health has launched a similar model that targets patients at risk for readmission. By identifying the patients most at risk, you can help save lives and reduce costs. Fcns could also help with vaccine outreach, health education, or one of the other many roles that trusted nurses play in rural communities, from answering questions about your child's rash to counseling during a mental health crisis. For the Fcns that I've met, their nursing role isn't just a job, it's a calling. And it's why so many of them do it for free. As we all know, if we are passionate about our work, we do a better job. So this proposal is an opportunity to harness that passion and maximize success and positive outcomes for your patients and community. Tracking usage and success is also critical, as Amy and Jan have mentioned. So whether you use a parish nursing system or your own electronic medical record, following up on patient outcomes and ideally costs would be important. And as referenced earlier, there's a paucity of research, so that if you're interested in doing some randomized control trials, there's really an opportunity here. Next slide. As I mentioned earlier, I am not an expert in faith community nursing. So I've spoken to many Fcns to try to understand what they do and how they are most effective. These conversations have also introduced me to a wide variety of potential collaborators. If this proposal is funded, the partnership possibilities are limitless, and that includes you. As you know more than anyone, rural hospitals are on a difficult path made much rockier by the pandemic. Out-of-the-box ideas are going to be critical to ensure your sustainability and longevity. Adding an Fcn to your staff could be one of the solutions that you're looking for. Next slide. So thank you for listening to all three of us, and I or any of the presenters here today welcome any questions in the chat or unmuting or however Becky would like. And I will go ahead and throw my email in the chat as well. Thank you so much.
Thank you, Katherine. This is Becky. I did have a question that was chatted to me early in Jan's presentation and was holding it till the end, and it had to do with documentation and the systems that were available. But I believe you already addressed that. But is there anything else anybody would like to add as to the kinds of systems that are available for documentation?
Well, that has been a big issue of finding what system works. And so the Henry Ford that was mentioned in the chat is one system. It is, I think it goes into the medical records. That's the key thing. If we are non-paid professional volunteers, we don't have access to medical records. But at the parish level, at the church level, we do keep our records. I have one nurse here at Community Health Network who's gathering little notes that the parish nurse takes and then is compiling it and to get the data and make a report. So to help tell the story right now, but we're not part of. Now with my program for readmission, that transitional care, I did get access to Epic and I could include my note, especially for that patient that I saw out in the community. So it's still a learning edge, a curve of moving towards that integration into the medical records. Yes.
And
Thank you.
The Henry Ford Macomb system that I use, it's not given out unless it is HIPAA protected. So it is congregational. And it is not shared. It is a medical record, you know, as far as the documentation system, but it is not and used as if it's a electronic medical record. But it is only shared with providers if the patient asks me to share it. They do. Other physicians or hospitals do not have access to it.
Thank you. The other question that came to me was the course that's taken, is it a certification or is it a course completion that would need to be provided?
So the course through the Westberg, the curriculum there is, it's like a 36 contact hours, or you could take it for credit hours. It is a course, it's not a certification. So certification for faith community nursing, like through ANA, is a special thing, but you'll have a completion, a certificate of completion, but not of certified you're a faith community nurse. That's a whole process through ANA. But yes, so it's just added contact hours, or if you're in a BSN or MSN, or even for a doctoral, to take a course in this, and it does count for credit hours. So that's been a misunderstanding too about the course. It's added extra continuing education.
Yeah.
Thanks, that helps. Don, those were the questions that came to me.
And I don't see any in the general chat other than lots of thanks for the presentations and that the information was very helpful.
Like I said, it's just the tip of the iceberg. Katherine and Amy are working front lines with it. It's very exciting, Katherine, that you have your proposal. So I hope that that does go through. We'll pray. We have contact, and we'll keep connected with this. Okay. I appreciate that information.
Great. So if you are interested in hearing more or learning more, why reach out to anyone of Jan, Katherine, or Amy, or you can reach out to Don Gettinger or myself, and we'll get everyone connected. But exciting information to hear, and definitely can see the great impact that faith community nursing has for the residents in their community. So great stuff.